Thank you very much, Giuseppe and Gabriella. Good morning, everybody, and thanks to Enzo for bringing me to this wonderful place. Never been in Mantua before. I'm not used to perform in a wonderful theater like this. My wife, as you know, is usually in our family the one who performs in a theater, but now it's once you give the chance, so thank you, Enzo, for that. And ladies and gentlemen, so what I will do during the next 30 minutes or so is to the first part of my talk is very clinical, and go back and look at what we have at hand as biomarker for diabetic nephropathy. And after that, to ask the question, can we do better? These are my disclosures. So first, a few words on the tools to screen for diabetic nephropathy or diabetic kidney disease. So when I'm using the term diabetic kidney disease, that's not the same as diabetic nephropathy necessarily, because diabetic nephropathy is the diabetic kidney disease that we see in type 1 diabetes. And in some proportion of patients with type 2 diabetes, we see true diabetic nephropathy. But some of them may have other etiologies like aging, hypertension, and obesity. So that's the reason why we use the term diabetic kidney disease. So then a few words by using these tools. What is the prevalence? What are the consequences? But the main question is, can we do better? Because we actually detect diabetic nephropathy and diabetic kidney disease too late. What about the clinical biomarkers, the ones that we are using every time? Could we use them? And then finally, can we ask for help from genetics? So the tools to screen for diabetic kidney disease. These are the three guys, the three musketeers of microalbuminuria. And Giancarlo Viberti, Italian in exile in London, on the right-hand side, Hans-Erik Parving and Karl-Erik Mogensen. These guys brought on board the concept of microalbuminuria. That was something that revolutionized the screening for diabetic kidney disease. And this was maybe Hans-Erik Parving said we should collect the urine, but maybe this is not the correct way of doing it. But Giancarlo did something in a study very long time ago. What he did here, you can see that at screening, he measured, when a radioimmunoassay, the albumin excretion rate. And 7 years later at the follow-up, there were a number of patients that had developed overt diabetic nephropathy. So now there was a tool to screen for diabetic nephropathy. But look at this, 30 microgram per minute. So Giancarlo used a cutoff of 30 microgram per minute. And I showed you a picture of Karl-Erik Mogensen. He used 15 microgram per minute, 1-5. And Hans-Erik Parving used 70 microgram per minute. So it was a little bit of a mess. And if you look at the definitions of albuminuria, we don't have to go through them, but we all know that microalbuminuria, this is the cutoff when the albustix gets positive. But do you know why we are using 20? Giancarlo was using 30 microgram. This is a story that has to do with Italy. Because since Karl-Erik Mogensen used 15, Giancarlo Viberti 30 microgram per minute, and Hans-Erik Parving 70. It was a chaos. So it was not the nephrologist or the endocrinologist or diabetologist that asked for clarification. It was the urologists. And they asked, they summoned a meeting in Padova, very close to Mantua. And the task was given to Karl-Erik Mogensen to clarify. So what did he do? He actually checked for the albumin excretion rate in the people around his own town of Aarhus in Denmark. And it just happened to be. The upper boundary of the normal range was 20 micrograms. So he presented that. And now all of us are using 20 micrograms per minute as a cutoff for microalbuminuria. So this has to do with Padua and Italy, and Dane was the one coming up with the idea of that cutoff. But it works. So when you then go out and screen for albuminuria, this is, you can see, 1 million individuals, more than 100,000 with diabetes, and you can see that the more albumin that leaks into the urine, the more likely the patients are to develop in terms of kidney disease. So it works. However, if you look at data from Paolo Fioretto, also from Padova, and the mix and the heterogeneity of diabetic kidney disease, it seems that those with microalbuminuria, they do not develop or progress in the same way. So that's the reason why we need other measures. And the estimated glomerular filtration rate is also something that we can use. And you can see that a drop in the eGFR of 30% has a ratio of 9.6, 40% drop, 20.3, and this is the 57% drop in eGFR has a ratio of 73. By the way, the reason why I'm showing this, the 57% drop in eGFR, that's doubling oral serum creatinine. So anytime you're using doubling oral serum creatinine, it means a 57% drop in the eGFR, and these are indicative now of established renal endpoint like end-stage renal disease, doubling oral serum creatinine or eGFR below 15, so you need dialysis. So these are the tools that we have been using now for years. So albuminuria and eGFR. So when you use these tools, what do you do? This is data from Italy, from Japan. Type 1 diabetes on the left, type 2 diabetes on the right, and you can see when you screen at random, the shaded area of those with diabetic kidney disease. So this is either a reduced eGFR of 60 or an increased albumin excretion rate. By the way, the reason why we are using 60 as a cutoff for chronic kidney disease is that it's 2 standard deviations below the average. Very simple. It's like 2.5 standard deviations below the average for osteoporosis or for the T-score. So this is equivalent to that, 2 standard deviations below the average. And you can see that if you look at the type 2 diabetic patients, it seems that quite a lot of patients at randomly screened will have signs of diabetic kidney disease. So then, if you go out and screen, as Hans-Henrik Parving did in the DEMAND study, on a global scale, 26,000 patients with type 2 diabetes, it turned out that if you screen for an eGFR below 60 or an albumin excretion rate above 30 microgram per gram, you can see 56% of the patients will have signs of diabetic kidney disease. So every second patient in your clinic will have diabetic kidney disease. And if you go to Asia, 68%, Central South America, 61%. So diabetic kidney disease is common when you use the ordinary screening tools of eGFR and albumin creatinine ratio. Now, what do these measures actually tell us from the clinical point of view? So the consequences of diabetic kidney disease. So here you can see these are data from the US. If a patient with type 2 diabetes has albuminuria or reduced eGFR or both, you can see there's a manifold increased risk of premature mortality. We have published from the Finnish diabetic nephropathy study similar data in type 1, and it's exactly the same. Immediately when you have an increased albumin excretion rate, you will have an increased risk of premature mortality. So it means that any time you find microalbuminuria or albuminuria or reduced eGFR, there is an increased risk of premature mortality. And this is very much due to cardiovascular mortality. So you can see the less the kidneys function, the more albumin that leaks into urine, the more likely the patients are to face a cardiovascular death. These are data in 10,000 patients from the ADVANCE study. If you then look at this study in 100,000 individuals or patients, you can see that exactly the same phenomenon. So a low eGFR and high ACR are indicative of a cardiovascular event or death. So then if you look at the eGFR solely, this is now 1 million patients and more than 100,000 with diabetes. You can see that the red is diabetes, blue is no diabetes, and you can see it's not only the cardiovascular mortality, but also all-cause mortality is the double in those with diabetes. And you can see that when you go below 60 ml per minute with eGFR, the increase of mortality increases. But on the right-hand side here, you can see albuminuria. Yes, the more albumin that leaks into the urine in this 1 million study is actually indicative of mortality. So these ordinary screening tools, they perform very well. And we can actually tell a lot what will happen to our patients when we're using them. If you also look at what they tell us in terms of heart failure, and since we're now talking about diabetic kidney disease, these are the guys that will develop heart failure. And you can see here, eGFR, a reduced eGFR or albuminuria, you can see that it's also predictive of hospitalization for heart failure. So these are quite good measures. However, if you look at the epidemiology of diabetic kidney disease, that's not much we have been able to do. Although we have, since the 80s, we have been using ACE inhibitors, and now, since a few years ago, we have started to also use SGLT2 inhibitors. But there is a much more we can do. So the question is, how can we detect signs of diabetic kidney disease much earlier? Like Ezio was talking about yesterday about very early stage disease. How can we do that? So let me now give some data from the Finnish diabetic nephropathy study, where we have looked at different urinary and serum biomarkers in order to detect diabetic kidney disease. So the first is LFAB, which is produced by the proximal tubal cells. And this is interesting because kidney disease is very much related to hypoxia. So it's a damage to the kidneys, because whenever you have an increase in blood flow, you will have a hyperfiltration. You push the sodium handling in the proximal tubal. You consume more oxygen. 90% of the oxygen consumption is due to proximal tubal sodium handling. So this is what happens in diabetes, but also in obesity, hypertension, and diabetes, as said. So hypoxia seems to be something that is indicative of the kidney disease. And it's interesting that this is actually released in a situation where you have kidney hypoxia. So what we looked at that, this is cross-sectional, so you can see that, yes, it's higher in those with micro and macrobinuria. And you look at the progressors, the baseline LFAB was higher at any stage at baseline in those that progressed. Then the question is this a better marker than albumin excretion rate? Now, always difficult to compete with the standard. If the standard is the albumin excretion rate, it's difficult to compete. However, this performed very well, and you can see that, yes, very nice. But on the other hand, look at this. In the micros, it went the other way around. Although it seems to be significantly associated with progression, it's not something that it seems to work perfectly well. And when you do the ROC curves and discrimination analysis, you will see that it will not add to AER. But LFAB is interesting from the pathogenic point of view. Now, let me now show you another biomarker, which is also a proximal tubal biomarker, adiponectin. And you can see that, again, this is the serum adiponectin, and you can see those that with microbinuria, they have higher. And you can see here, so the progressors that progressed, that higher serum adiponectin. If you look at the urine, also at the normal AR, macrobinuria, the progressors had higher levels of adiponectin. So what about this? Is this a better predictor? Maybe not, because although there is some benefit when you look at the ROC curves and the discrimination analysis, it's not going to outperform the very easy AER. But interesting also from the point of view what happens in diabetic kidney disease in the proximal tubal. A third biomarker that is coming from the proximal tubal that had now raised a lot of interest is the KIM1, and it comes out in many platforms where you test for biomarkers for diabetic kidney disease. But you can see here, if you look at the normal macro here, yes, it's higher in the macroalbuminuria patients. And if you also look at the ones that progressed, you can see at baseline higher KIM1 at baseline if they progressed. However, it didn't actually predict the progression of the kidney disease. Now, urinary KIM1 is interesting because you can look at the genes, and it's genetically determined. You can see very strongly association with SNPs. And it's interesting when you do that, you can actually utilize the KIM1 and the association with KIM1 by using a Mendelian randomization. And it turned out when you do this operation here, you can see that KIM1 is actually causally related to the kidney disease. So maybe this biomarker could provide some help in terms of understanding the disease progress, but not as a biomarker. So these were ordinary biomarkers in the urine and serum that we measured, but as I told you, it's difficult to compete with the standard. and the standard is the AER, and you always compare with the AER. Now, let's switch gears a little bit and talk about metabolomics. This is a data we published in JASN quite a few years ago. And you can see that in 85 patients with diabetes and kidney disease and 73 without kidney disease. And it turned out that 13 metabolites, this was a mass spec, a targeted mass spec metabolomics, were associated with diabetic kidney disease. And you can see that 12 out of 13, it's difficult to see here, but I can tell you 12 out of 13 were mitochondrial metabolites. So they came from the mitochondria, which is interesting. The heart cells are the ones with the highest number of mitochondria in the body. The second cell type is the proximal tubule. And it must be a reason why we have the highest number of mitochondria. And just told you that 90% of the oxygen consumption is also due to sodium handling in the proximal tubule. So mitochondrial dysfunction, it seems to be part of this. And actually, when you look at exosomes and you look at the mitochondrial DNA, you can see in diabetes it's down. But if you look at the PGC1, which is the main switch here, you can see in diabetic nephropathy it's down. So you have actually signs of mitochondrial dysfunction. The reason why I'm showing this, because there is now another study that was published, actually made public in Melbourne in the spring, after giving dapagliflozin. And they used this exactly the same targeted metabolomic approach. You can see that you have a change in the signal. So it may be that metabolomics is something that we could in the future use to detect diabetic kidney disease at earlier stages. Is this early enough? These patients in this paper that we published here is actually quite late stage. So let's then have a look at if we go for very early stages. This is a paper that we did together with Ele Ferranini from Pisa. And you can see that this was a metabolon platform. And it's interesting that we had 1 or 2 individuals that, after a median follow-up of 3.2 years, progressed from normal excretion rate to microglobinuria. And then there were 98 that remained normal minuric, although the follow-up was 7.1 years. And it was a screen of more than 1,200 metabolites. And it was interesting that the predictive metabolites, here you can see, these are the top 30 of those 1,242. And the predictive ones has very much to do with uremic toxins and carnitine metabolism. Carnitine metabolism, what is that? It's basically when you eat red meat. So maybe this is something that we can pick up also what happens when the environmental factor. So what we used from this screen here, the top 4 here, we performed or made a metabolic index based on these 3 metabolites. And we looked at how this index performs, and you can see it actually performs better than the clinical variables. And the clinical variables here are age of onset of diabetes, baseline A1C, and of course AER. And if you then look at the progression here, yes, those in the upper quartile, showed progression. So this might be a very early sign of progression at the early stage. So this is maybe something for your stage 1 that we really can try to detect them earlier. Now, we have also a recent data. This is unpublished data. We presented them at the ESD this year, and this was 2,500 patients, and here we used NMR, so nuclear magnetic resonance, and in the urine. And what we can see here, so these are the normal minuric patients, macrominuric patients, microminuric patients. So we looked at progression from normal to micro, from micro to macro, and we had about 340 pooled progression events. So early progression, late progression. And if you then look at the pooled progression, you can see here, these are a number of metabolites, and quite a few of them you can recognize. So leucine, valine, isobutyrate, etc., etc. And if you then look at the early progression, to some extent the same ones, but not all. Tryptophan is interesting, and Anna, you're sitting there, you know you have published a paper on the tryptophan and type 2. So they tend to come up all these in different populations too. And if you look at late progression, it seems to be these amino acids. So if you put them together, this is the pooled progression, early progression, and late progression. It seems that leucine and valine are coming out, like here, and for late progression. And if you then look at glycine, it doesn't come up here significantly, but for late progression, the tryptophan and hydroxybutyrate, you can see how they perform here for early progression. So this is using a very simple tool, which is the NMR of the urine. And in this platform, we have up to 28 metabolites, but we are increasing it. We'll come up to about 60, 65 metabolites. So what do we know about these biomarkers that came out from this screen? You can see that the branched-chain amino acid, leucine and valine, serum levels are associated with future insulin resistance and type 2 diabetes that have been published before. When it comes to one of these ketone bodies here, you can see that serum levels are associated with insulin resistance, and they have also been associated with type 2 diabetes and also aggressive subtype of type 1 diabetes. Glycine, interesting metabolite. In animal models, you can see that serum glycine is renoprotective. This is connected also to the glucagon secretion. And we have published a SNP that is actually in a gene that is associated with albuminuria that has to do with the glycine metabolism. So urinary glycine in the Framingham cohort for declining eGFR below 60, an odds ratio of 0.59. And you can see in our study early progression 0.6, but late progression 1.22. So it's not always perfect. So they seem to perform, but then there's something always, something comes along. The tryptophan, this is the paper that Anna was alluding to, published that tryptophan is also a very interesting one that seems to pop up very often. So this is how we can use metabolomics of urine. What about then metabolomics of serum? This is quite an old data set that we published in Metabolomics 2011, so 240 patients without kidney disease and 86 with kidney disease, and using the NMR. So this is basically the same NMR platform that we use for urine, but here we also screen for lipids, so you have to do some further manipulation of the samples to also to get the lipid lipoproteins. And here you can see these are the ordinary low molecular weight metabolites and albumin, what you can see usually. So in this screen, this is now truncated here because I just showed the top. You can see it's a very interesting molecule that comes up, sphingomyelin. And I remember, so this was 2011, and we haven't done anything to this sphingomyelin. But on the other hand, there's a lot of papers associating sphingomyelin with instability of LDL molecules, etc., etc. But we didn't do much to this. But now, 2 years ago, we actually started to look into this again in the Findayan, and you can see in 1,000 patients, sphingomyelin, when you look at a decline in the eGFR or progression to end-stage renal disease, it turns out to be predictive of both. And you can see that if you adjust for a lot of variables, it still turns out to be a predictive of declining eGFR and progression of kidney disease. So this sphingomyelin may also be something that we in the future are going to use. So this was a long story about nothing about many results, because the problem is here again, how can we compete with AER? But some lights in the horizon still from these biomarker studies, because we need to do better. But let me just briefly tell you about what we see in the clinic. because I suspect many of us in the hall here are seeing patients on a routine basis. So just let me give you a few hints of what we can find by just looking at the patients and testing the patients. And you can see that age of onset of diabetes in type 1, this is now type 1 diabetes again. You can see if kids develop diabetes between 0 and 4 years or 5 and 9 years, the risk of end-stage renal disease is exactly the same in boys and girls. If they develop in puberty or after puberty, the boys will have the same risk, but not the girls will be to some extent protected. So will this mean that exposure to glucose will destroy the reproductive system? We don't know. But it's interesting. So even the age at onset is interesting for predicting of end-stage renal disease. And also, if you just look at the prevalence of components of the metabolic syndrome in patients with type 1 diabetes, this is something that we are used in the general population and in the type 2 population. I have put it within brackets because you can see abdominal obesity is not the main driver. So this is slightly different, but it's still the components of metabolic syndrome. And 40% of patients with type 1 diabetes have components of the metabolic syndrome. And if you count the components, you can see the more components you have, the more likely the patients are to progress in terms of diabetic kidney disease. So very easy clinical measure. If you look at lipids, this is patients that progress from normal to micro, and you can see that the total cholesterol slightly higher, non-HDL cholesterol slightly higher, triglycerides slightly higher, and you can see that ApoB slightly higher. But these are within the normal range. So even a small switch within the normal range seems to be predictive of progression of kidney disease, because you see triglycerides also come out in a Cox progression model. And here you can see that this is the same, the true at baseline for normaluria, microalbuminuria, and macroalbuminuria. So slightly higher triglycerides are indicative of progression of kidney disease, and of course insulin resistance. So they all come together. But just let me finish off one very simple observation, and this is that if your patients are not doing intensive physical activity, you can see here, high intensity is actually preventing the progression of kidney disease or incident kidney disease. It's not the total amount of physical exercise. I'm physically active here. It doesn't matter. I need to sweat to actually have to achieve this. So this is just to say that we should not underestimate also just the clinical biomarkers. And finally, a few words on, can genetics help? Because AR and EGFR, we have had them at our hands a long time, and they have seemed to be extremely helpful, but we would like to find the patient much earlier. And type 1 diabetes, there is a genetic propensity. Also for diabetic nephropathy, in type 1 diabetes, there is a genetic propensity. And you can see that if you have 2 kids in the family with type 1 diabetes and the proband has diabetic nephropathy, the likelihood that the other will also develop diabetic nephropathy is much, much higher. By the way, Eze was yesterday showing that if the mother has type 1 diabetes, the risk of the sibling to develop type 1 diabetes is 4 times higher. But if the father has, it's 8 times higher. But it's interesting. If you look at the risk of the kid to develop diabetic nephropathy, if the mother has type 1 diabetes, it's 4 times higher. So it goes the other way around. For the risk for diabetic nephropathy, if both the mother and the sibling has type 1 diabetes. This is very interesting. But you also can see here, when you look at the heritability, it's about 35%. So there is some genetic propensity. And let me just give you one example that was published now in JASN actually last week. And this is now in about 20,000 patients with type 1 diabetes. It's a collaboration with a lot of co-workers around the world, and 16 loci with genome-wide significant findings. And you can see here in different cohorts. Italy is also here involved, actually the surroundings around Milan, Giampaolo Servini. And you can see here, they are all consistent. Most of them are consistent on the left-hand side of the unity line. So 0.79. So this seems to be a protective SNP. And you can see that if you look at the different phenotypes with macrobinuria, encephalitis disease, etc., they're all on the left-hand side. So it seems that this is a true diabetic nephropathy gene. Now, we always been intrigued by the fact that some people in our clinic have a high A1C and no complications. And sometimes we have a patient with, let's say, not normal, but slightly higher A1C and all the complications. So maybe this might be one of the explanations here, because if you have an A1C above 7.5, this SNP in the collagen for A3 gene is actually protected, but not if you have a normal A1C. Is this going to help us in terms of screening or detecting diabetic nephropathy? I don't think so. This might rather help us to understand the pathogenesis of the kidney disease. So when it comes to the biomarkers to detect early diabetic kidney disease or to use in the clinical management, we still come back to the ordinary ones, which is albumin excretion rate and eGFR. And the three musketeers of the microglobinuria, although that was in the 70s, they seem to be right, and they do a great job for our community. So a few take-home messages, Gabriella and Giuseppe. Albuminuria and GFR are still the cornerstones of screening for diabetic kidney disease or diabetic nephropathy in patients with type 1 diabetes, although there are some promising new urinary biomarkers, LFAB, adiponectin, KIM1, how to use these. They all predict the progression of kidney disease, but they don't outperform the standard, which is the AER, and that is, of course, the problem. Adiponectin might provide some benefit. Metabolomics may provide a better tool to detect early diabetic kidney disease that I showed you from the Metabolon platform by using that index that outperformed the AER. However, we should not underestimate and ignore the clinical biomarkers, because we can actually judge a lot of what will happen to our patients by using those. And genetics may not improve our abilities to detect early diabetic kidney disease, but can definitely improve our understanding of the disease progresses. So my final conclusion is actually this. Albuminuria and reduced eGFR are not only laboratory measures, they are a call for action. Because when you find albuminuria and when you find a reduced eGFR, actually the grim consequences. Increased risk of premature mortality, increased risk of cardiovascular events, increased risk of ending up on dialysis. If you are a type 2 diabetic patient, you will also see a very much increased risk of severe hypoglycemia. So these are a call for action. And before I stop, these are the guys that have done the work in the FINDIAN that I showed you. And that said, thank you for attention.
Thank you, Frederic, for your beautiful presentation, which is now open for discussion. I see one hand over there. Another one.
Thank you very much for your talk.
Thanks.
Wonderful. I'm Rocky Strollo from Rome. So is there any evidence for involvement of autoimmunity in diabetic nephropathy? In other words, is there any autoimmune reactivity to, for example, glomeruli? Because I'm thinking that collagen is glycated, oxidated, and this may generate neoepitopes, and therefore autoimmunity can more easily develop in these patients.
Yeah, it's a good question. I'm afraid I don't have the answer to that, but we are looking into autoimmunity now with collaborators from the Jocelyn. Is it autoimmunity? Is it inflammation? Or what is it? I would say that inflammation definitely is something that is related to diabetic kidney disease. Is it autoimmunity? We don't know. But we are testing that. I doubt it. because I think it's more inflammatory process. And let me tell you the reason why I'm saying this. Because we published a paper in, I think it was in Diabetes Care quite a few years ago, where we showed that LPS, components of gram-negative bacteria, is associated with the progression of kidney disease. Actually, at baseline, in those that progressed to diabetic kidney disease 5 years later, they had higher levels of LPS. And you know, LPS is used to induce kidney disease in mice and in the... So that was intriguing finding. And we started to think where can we get these LPS from? And is it from the mouth? Is it from the lungs? Or is it from the gut? And it's interesting that people with diabetic nephropathy, I didn't show slides about that, but they also have an inflammation with higher calprotectin levels at the same level as people with Crohn's disease and colitis ulcerosa. And it's interesting that this intestinal inflammation seems to be regulated by intestinal alkaline phosphatase, which actually dephosphorates the LPS. So there's a crosstalk between inflammation or infections and the kidney disease. And toll-like receptor is the receptor for the LPS, and that is also found in the proximal tubal cells. Back to the autoimmunity, we haven't actually looked at autoimmunity, but as I said, we are going to try to see that is more focused on retinopathy, but still we try to address the question that you are asking.
Very nice talk, thanks. I think the size of the Findayan study, the size of the court, as well as the very accurate follow-up, for sure would allow you to evaluate the role of the variability over time of the main cardiovascular risk factors, I would say, stick to the clinical parameters.
True.
Is there any role of the variability of HbA1c or fasting plasma glucose blood pressure in predicting the decline in this course?
Yeah, and thank you for that question. Yes, we were intrigued by the data from the DCCT trial, showing that if you do seven-point glucose measurements during a day, and you look at the variability, you would expect that the higher the variability, the more that translates in complications, and it was shown that it's not. So we asked the question, what about A1C variability? And it turned out that when you do serial A1Cs level of 30 over a period of time, 13, 14 years, the A1C variability is as strong predictor of progression of kidney disease as the high mean A1C. And it's interesting that the variability, if you look at the standard deviation, and if you look at the median above the average, and for the average A1C, and also for the standard deviation, you can see that the progression rate is the fastest. And it's interesting that the effect of a highly variable A1C and high A1C exactly the same. And if both are below the medium, then you have the lowest progression rate. So yes, variability of the common risk factors are definitely important. We also looked at the same phenomenon for HDL, for triglycerides, for cholesterol, hypertension, and it turns out that it's exactly this phenomenon. So exposure to biomarkers are definitely risk factors. And of course, then you can question, why is the variability? I think that is linked to some phenomena that is actually maybe something else that makes that your metabolism is highly variable. But the effect of high A1C and highly variable A1C is exactly the same. So good point, and yes, and we have shown that. Go ahead.
I don't know. Microphone.
Okay, Going back to inflammation, of course you know the paper from the Joslin group, and they were reporting a signature, an inflammatory signature related to diabetic nephropathy, and probably addressing TNF-alpha receptor and related signaling. I wonder whether you had the chance to look at the same signature in your sample.
Yeah, good. Thank you for that question. Actually, I had already too many slides this morning. I deleted the data on the TNF-alpha receptor. So we published a paper in Diabetes Care 4 years ago that, yes, it's predictive. But again, then you have to fiddle around with the data a lot. And I'm saying fiddle around because when we looked at the data in the first place and compared with LV excretion rate, it really didn't turn out to be outperforming the AR. But when you do the discrimination analysis, actually you can see that you have an add-on. So the findings from the Joslin is absolutely true, and we have replicated that. So the TNF-alpha receptor actually works. Here's you.
Thank you. Lovely, very informative. The genetics. So, first of all, stage 4, when you have diabetic kidney or, albuminuria, etc., it would be stage 4 in the classification.
In your classification.
It looks to me like there could be a case for a genetic risk score that may be able to predict those more likely. And I guess my question is it worthwhile to do that for the sense of being able to prevent the appearance of microalbuminuria, etc., with certain trials? And I think that's, again, coming back to this very, very early prediction. That's the first question. The other comment on the autoimmunity, I was just thinking, there are some minor autoantibodies in type 1 diabetes at diagnosis, including mitochondrial things. You never know. They may associate with that, and it might be worth looking at that. But I'd be interested to hear about the prevention of that
so using
genetically at-risk people.
Yeah. So using genetic risk scores. This is something that we are now, of course, starting to use. The problem with diabetic nephropathy, let me just give you the background, why it's so much more difficult to do genetics on diabetic nephropathy. If you look at a very easy measure, which is the lambda S score, that tells you the probability of that genes are involved. So cystic fibrosis of lambda S value of 500. We know the gene defect. MODY, we know it's 40, and we know 6-7 different gene defects, even more. Type 1 diabetes, 15, and we can explain 50% of the HLA, and another, I think you showed 25 additional SNPs on top of that when you use the genetic risk score. But lambda S value is 40. For type 2 diabetes, that didn't seem to be very easy, a lambda S value of 3.5. Now we have 200 SNPs that explain maybe 5-10%, but still, what about diabetic nephropathy? It's a lambda S value of 2.3, 2.1, 2.3, as I showed you in the picture. So and the numbers of patients with type 1 diabetes, although I come from Finland with the highest incidence rate of type 1 diabetes in the world, but to get the numbers that people that are doing type 2 diabetes genetics, it's difficult. So this data set that we now published, we gathered DNAs from different parts of the world, US and in Europe. We got 20,000 patients. So I'm a little bit envious about the genetic studies in type 2. And of course, genetic risk scores is something that now when we have these top hits, and we have a few from before that we have published, so yes, we are looking into it now, and hopefully we can detect much earlier. But as I said, I think at this stage, it will provide more information about the pathogenesis. But I do hope that we can find the measures to detect much earlier, because the consequence of diabetic nephropathy are grim. Silence.
Please. You confirmed the
okay.
You confirmed the information of relationship between albuminuria and reduced glomerular filtration rate and cardiovascular disease. What do you think could be the mechanism? It's a matter which involves endothelial dysfunction, of which microbiota could be the very first sign, or has to do with hypertension. What do you think about that?
Okay, this is my favorite topic, so if you give me another 10 minutes, I will tell you. I do believe, actually, I've been wondering, why do people with diabetes develop kidney disease? Type 2, type 1. Why do people with hypertension develop kidney disease? Why do people with obesity develop kidney disease? There must be something common. And if you look at the histology in all this, it's very similar. FSGS in obesity is not far away from diabetic nephropathy in type 1 diabetes. If you look at nephrosclerosis in hypertension, people with type 2 diabetes and diabetic kidney disease, many of them have nephrosclerosis. So what could be the driving force behind and the mechanism? And as a unifying hypothesis, and my take home of this, or taking of this, is all of this go with increased renal blood flow. And increased renal blood flow leads to hyperfiltration in the glomeruli. And any time you have hyperfiltration, you push the sodium handling in the proximal tubule. And as I told you, 90% is actually of the oxygen consumption is due to the sodium handling in the proximal tubule. And you know, when you, in diabetes, and when you push the sodium handling, you will have a exaggeration of the sodium reabsorption. Not only glucose, but also the sodium. And sodium is not reaching the macula densa. And macula densa functions as a control tower of the glomerulus. So if sodium is not reaching the macula densa, not reabsorbed with another countertransporter consisting of sodium, chloride, and potassium, you are not generating adenosine, which is a very strong vasoconstrictor of the afferent arteriole. So I think this is very much what's going on here. That and if you push the sodium handling, you will cause kidney hypoxia. And why do I say that? We know that, for instance, an operation, you are at very high risk of acute kidney injury. If you have a septicemia, you will have huge increased risk of acute kidney injury. They also go with what I told you about LPS, etc., and the effect on the proximal tubule. So kidney hypoxia is something that I do believe is behind it. And the reason why I'm saying that, when you induce diabetes into experimental animals, you will cause within 3 days kidney hypoxia. And that's continuous. And if you then induce kidney hypoxia without diabetes, without reactive oxidase species, you give a drug called dinitrophenol, which is a mitochondrial uncoupler. So you cause kidney hypoxia. And you look, what is the phenotype? Proteinuria, positive Vimentin cell damage, inflammation. So by causing kidney hypoxia, you will have the hallmarks of what we see in the kidney disease. Not only diabetic kidney disease, but also in kidney disease. And I think the clinical support for this theory that you actually have increased renal blood flow and hyperfiltration is that we will look at what we can achieve with SGLT2 inhibitors. Dramatic effect within exposure in 2 years to, for instance, in the credence that canagliflozin, you will have a dramatic improvement and you preserve the kidney function. So I think this is one of the drivers. But hypertension is important. Intraglomerular pressure, so glomerular hypertension is important. Inflammation is important. But I do think that the main driver is the hypoxia. And keep in mind that 25% of the cardiac output reaches the kidneys. So the kidneys have to protect themselves against too much oxygen, because oxygen is toxic. And you look at the gradient between the renal artery, renal vein, and the tissue, you will see a very subtle gradient. So at the expense of hypoxia in a situation where you have diabetes, obesity, and hypertension. I can't say that this is true, but I think this is something that we have to look into. And I think instead of looking at the small parts of the puzzle, I think we need to look at a more holistic view here. Long answer, but sorry for that.
Lovely talk. Over here. From a simple clinical point of view, the slide you showed of the difference between men and women, depending on the age of onset, is fascinating. Now, of course, one of the biggest differences between men and women, which is highly relevant to nephropathy, is the level of blood pressure, as you've just been saying. But can this possibly explain this large difference? How does blood pressure actually play into that difference you saw? For instance, do women who develop their type 1 diabetes before puberty have the same blood pressure as men? It seems unlikely, but I don't know the data.
As a matter of fact, I need to go back. Right? I'm sorry for that. I need to go back. My feeling is that they are the same, but I need to go back and check that. It's an interesting point, but still, what I think the more I look at the data of age at onset, is that we are looking at maybe slightly different disease, and I think this is important because the earlier you get type 1 diabetes, the more disease you have. And we have done quite a lot of work on late onset type 1 diabetes, even late onset. And there are some differences between these. But again, if you come back to if the blood pressure will explain, I don't think so. But you know that it's interesting, any time you look at male sex is a risk factor for diabetic nephropathy. But it's interesting, when you look at the reason why you see much more in the men, is that the absolute risk is higher. If you look at the relative risk and you look at the different levels in the males and females, when they have diabetic nephropathy, the risk of any of the cardiovascular disease or anything of that is exactly the same. And also the risk of diabetic nephropathy when you have the first signs of microbinuria is exactly the same. So I think the difference between the males and females is more subtle than we think. But I just wanted to point it out that since we heard yesterday wonderful talks about type 1 diabetes, that this is something that might also play into the females are, well, they are menstruating, they are protected against the cardiovascular disease. If a patient with type 1 diabetes develops signs of diabetic kidney disease, they are not protected at all. And then the risk is exactly the same for diabetic nephropathy and cardiovascular disease, even higher for the cardiovascular disease.
Enzo, here. I'm here.
Oh,
thanks
Enzo.
a lot. Very nice talk. Thanks a lot. I was impressed by the difference of the prevalence of diabetic nephropathy and type 2 diabetes between Italy and the other countries and the other studies. It was 60% on average in the others and 37% in our study, we just studied. What are your ideas? It's a matter of the sample or it's a matter of the country, the population, the background population?
Do you want me to
the
be
environment,
polite?
the food, the sun, music, soccer?
Right. I think, the Mediterranean diet and the music, this is fantastic. I spent now a week on vacation in Italy. I can tell you, I'm so fantastic country. So when it comes to screening, let's keep in mind that Hansen Parvin study was screening at random. You go out and screen. And I think it might be done different in different parts of the world. On the other hand, I think the main message is that diabetic kidney disease, the prevalence is much higher in Asia and in Latin America than in Caucasians, so in Europe. So I think the 37% that you see in Italy is very much true, but it's close to the let's say every second one. But on a global scale, when you look at Asia, for instance, where is the type 2 diabetes boom? That's in India and in China. And they have a very high risk of diabetic kidney disease that comes with green consequence. This is clinically something which is astonishing and quite scary. But I think the 37% in that is very similar to what we would expect in Europeans. But I still think that Mediterranean diet and the sun and wonderful wine from this area helps, and the music.
Gabriella?
Thank you very much. A beautiful talk. I have just a question, very brief. You didn't mention CKD 273. Did you have the chance to test this level in your cohort?
So in the Findayan,
Yes.
the prevalence of CKD.
No, CKD 273, the biomarker.
No, exactly, yes. Oh, yeah, that was also one of the slides that I took out this morning. No, we haven't done it in the Findayan. The Danes have done that. That's, of course, another measure that you might utilize. And it seems now that the CKD 233 is providing some, let's say, more insight. But again, I think what it tells us is that when you have damage, so again, will that outperform AER? I'm not so sure, and it's quite an expensive procedure. So, but you are absolutely right.